welcome everybody. Jo Neal here. I'm your host for today. So very warm welcome to another brilliant, I'm so excited about this one, Street Drugs Discussions webinar. So today our topic is women, hurrah, women and drugs. And actually this is often overlooked and underexplored area and underfunded for research. But it's such an overlooked aspect of so many aspects of our lives. The kind of the world is designed around men. But in medicine, in therapy, in interventions, clinical trials, and there's some resistance from some of the professionals to changing this. And over half the world's population are women. You know, it's nuts. So, for example, I used female rats in all my original early drug discovery work. And every paper I wrote, I got asked to justify why I was using rats and what about the estrous cycle? Was that not going to mess up the results? So I started asking people to justify their use of male rats, male cells, male systems. So research is really male dominated, and we really need to change that. And women go through many stages of their lives where significant hormonal changes occur, and that will impact their response to many things, but not least of all, drugs. So puberty, menopause, particularly relevant to me, perimenopause, pregnancy, breastfeeding, and of course there are many, you know, female conditions such as polycystic ovarian syndrome and menstrual cycle syndromes. So today we're going to explore how this interacts with drug use and inequalities in the treatment of women generally. And we have three absolutely fantastic women to help us do that, everybody. So thank you all for coming. And I'm not going to talk any more just now, but I'm going to introduce you to our first speaker, Dr. Grace Blest-Hopley. She's a reserve officer in the British Army. She's also a postdoc at King's Uni, a research director at Heroic Hearts Project UK. That is a combat veteran charity. She is CFO at NW PharmTech, which is a clinical stage biotech. She is now, folks, this is really important. She is the founder of Hystelica, which is all things psychedelics and women. And I highly recommend you go to the website and have a look at what they're up to. Well, I'm sure she will talk about it, but it's absolutely brilliant, brilliant organization. Thank you very much for being here, Grace.
Thank you so much for having me. Am I okay to just start sharing my screen?
Yeah, please do.
Excellent. Hopefully that will come up. Let me know when you all see it. Are you there? Great.
Yeah.
Well, thank you so much for inviting me here, Joe. It's really amazing to come and have this discussion. And when you told me the topic, I was, trying to think, how I could take what I've been doing so far, which has really been looking very specifically around women and psychedelics, and looking at, possible indications that we could treat in women with psychedelics. But when I sort of go back through all the theory and the logic of why Hystelica is important, it's all extremely relevant to this talk because, the reason Hystelica exists is that we have this vast gap in our understanding of women's biology. And what that means is that we don't fully know how female bodies respond to various different substances and various different drugs. But it goes beyond that, and it looks a little more in terms of thinking, well, why do people use substances in any way? I think it's perfectly acceptable that people might use substances in recreational ways because they want to enjoy themselves. But we also know that a lot of people's patterns of behavior with drug use can be very associated with things like their mindset, like their mental health, like their physical health and well-being. So if we just pause for a minute and just have a look at what we mean when we talk about women's health and well-being, why I think it's important that we have a particular lens onto women. It's things like premenstrual conditions, like you mentioned. As I'm sure we all know, women in their reproductive years have a menstrual cycle, and the latter parts of that menstrual cycle can be highly associated with large changes in behavior and in mood and in emotional regulation. And they can exist in things like PMS, which unfortunately affects sort of 75% of menstruating women. But we can also see extremely severe forms of that disorder in things like PMDD, premenstrual dysphoric disorder, which is actually a DSM-5 diagnosable disorder of extreme premenstrual symptoms, and things like PME, which is where we see people who already have underlying mental health conditions having the symptoms of those exacerbated before menstruation. And of course, finally, menopause. All women, if they are lucky enough to live long enough, will go through menopause. And there are a huge number of associated mental health risks and changes in emotion and cognition. We know because of a lot of this and a lot of the hormonal effects that take place in women that I'll come on to talk about in a moment, that women are much more likely to experience mental health problems compared to men. Now, I do want to caveat that with a little that women are better at help seeking, and it could be that there is some biasing from that. But we do seem to see that there is quite a different prevalence across a number of different mental health disorders that could very well be associated with things specific to female biology and female psychology and sociology. Now, one of the big issues we also see is that women who do have varying different numbers of, be they mental health disorders or often chronic health disorders, things like autoimmune disorders, things like chronic pain, these are more prevalent in women and they are often misdiagnosed in women. And furthermore, women are often sort of gaslit and undertreated in these areas. And that can often lead people to perhaps seek other options of relief from the symptoms that they're experiencing. Now, we know that, for instance, 70% of individuals with chronic pain are women, and we know that it's definitely been seen to be sexually dimorphic in terms of how men and women experience pain. And when we think about the drivers of drug use, issues with emotional regulation and things like pain perception can be big drivers in people's behaviors there. Now, why might the female biology be playing a part in this? Well, I hope this is all a very obvious recap for many of you in terms of what the female hormone systems look like. As I said, we have a hormonal life cycle where we have our menstrual cycle starting during puberty and ending at menopause. And once we finish our reproductive years, we go through what we call perimenopause, which is a phase of around 10 years, where we see these huge fluctuations in things like estrogen before our hormone levels drop off in menopause. Now, if we take a bit of a lens and look at that on a monthly basis, we can see from this right-hand graph that we've got a very delicate orchestra that takes place within our body. Our body really works like an extremely well-tuned clock in order for different hormones like estradiol to rise, which then do things like trigger ovulation, and then we see heightened progesterone in the second half of our cycle. Now, why is any of that important to what we're talking about here? Well, beyond reproductive cycles, we are animals after all. We don't just have hormones so that we can reproduce. They're also hugely powerful neurosteroids, which are acting in all different parts of our bodies, but particularly in our brains, to impact things like our brain functioning, our psychological well-being, and our overall health. But it's not just hormones within women that make a difference in terms of our behaviors and in terms of perhaps how we engage with our environment around us and with things like substance use. And it's far beyond the scope of my talk with you today, but I think it's really important for me to stress that the biological factors I've outlined here in terms of the changes in the endocrine system and female hormones also play together with things like psychological stressors and things like social stressors, which also play a lot into women's health and well-being. Now, what is the link between any of these hormones and things like pain and stress and our brain health? Well, if we look at estrogen, for instance, the primary hormone in female reproduction, we see that it has a huge impact on things like the serotonin system. So enhances serotonin production, prolongs availability of the receptors. It also does things like regulate dopamine and dopamine sensitivity. Now, we know that's going to be really important with for instance, females who have ADHD or females who are potentially reward seeking in their behaviors, because we know that the dopaminergic system is so involved in that. Furthermore, we know that estrogen promotes things like neuroplasticity and dendritic spine density. It has neuroprotective effects and further modulates glutamate release and uptake. Now, when we move on to progesterone, the second, key female hormone, we see something very interesting. Now, progesterone breaks down into a metabolite, allopregnanolone, which actually works on our GABAergic system, and it works a little bit in a similar way that how we perceive things like alcohol to work by increasing the amount of activity in the GABAergic system and having these lovely anxiolytic effects. It furthermore then plays into a lot of our mood regulation, a lot of our emotional processing, and works alongside estrogen to regulate brain function and reduce things like neuroinflammation. So we can see that these two hormones are having a big impact in how our brain is working, how our brain is processing, and how our brain is actually staying healthy in terms of its plasticity and neuroprotection. Now, when we look at this graph here, this shows how we see a variation in estrogen and pain scores. So what happens in our brain is when we have estrogen going from high levels to low levels, so estrogen helps us to uh, basically feel less pain. But when we have sudden drops in estrogen, like right after ovulation or right before menstruation, women actually have an increase to pain sensitivity. So it could even, and furthermore, more than, sorry, my dog is busy. Further than just having an increase in the amount of pain we feel, we also see that there are then changes in how our body metabolizes things like pain medications, so anti-inflammatory drugs. So these could be less effective at different times in our cycle. And the final thing that I think is important about female biology to understand, and I'm sure you're getting that this is a very complicated picture where we've got a lot of different hormones moving in different directions, affecting different parts of our brain. So it's not as clear as one state equals one outcome. But on top of all of that, we have our HPA axis, which is our stress response system. And what we see is that our stress response changes throughout the menstrual cycle. So at the first half, the first 2 weeks, what we would call the follicular phase, we see that our base level cortisol levels are higher, but our response to a stressor is lower. And that is reversed in the luteal phase. So we have lower base level cortisol, but so we might have less sort of get up and go and sort of energy in that part, but we have a increased spike in cortisol when we come across a stressful activity. So we may be more susceptible to feeling the effects of stress in the latter half of our menstrual cycle. Now, I think that's all extremely important when we think about women and how they might be engaging in any drug using activity. And we do actually see that there are changes in people's reward sensitivity and changes in their risk taking behavior based off of different levels of hormones. Now, actually, when we have very high levels of estrogen, that in itself can be associated with people looking for more risk-taking behaviors. And if you think about the biology of, what we need to do behaviorally right before ovulation, perhaps it makes more sense for us to be, more outgoing and more risk-taking in what we do. But we've actually seen this play out, and we're going to come on with some of our other speakers who are going to look at this in much more detail. And we do see that it changes the amount of substances that people use depending on where they are at different parts of their cycle. And furthermore, we think that a lot of this can be driven by, as I said earlier, this effect of estrogen with dopamine and how we can potentially have differing effects at different parts of our cycle. Now, as I've mentioned in terms of body and mindset, our hormonal influences are having a huge influence on things like mood and pain and emotional processing. So it's important that we consider there could be influences of our cycle and our hormonal profile that are playing into our behaviors and how we might want to engage with substances. Furthermore, I think it's important for us to think not just about the behavior or the choice to use a substance, but how we're actually going to feel when we're under the influence of the substance because of these mechanistic synergies that we see within the brain. For instance, like estrogen affecting the serotonergic system and things like psilocybin affecting the serotonergic system. It could be that your experience under the drug is changed as a result of your hormones. And more than just our hormones, we see changes in our metabolism. So it could also be that the amount of time that it takes our bodies to break down drugs is changing as our hormones fluctuate. And that's before we even start saying, well, are we different from men? I think it's important to see here, we need to think about the differences just in women, not just the differences between men and women. And we've seen that certainly play out in what we've had in terms of drug development, in that there are 50 to 75% more likely for women to experience adverse drug reactions than men. Now, a lot of the reason for that is because, as was pointed out by Joe at the start of this, there has been, unfortunately, a systematic under-researching of women and women's bodies. And we've always kind of retrofitted to a man's model. And that means that things like adverse drug reactions are often not fully explored and not fully picked up in clinical trials in women. So, does it really matter? Do we actually see these differences beyond this sort of theoretical idea that the hormonal mechanisms are affecting similar areas of the brain? Well, yes, I think we do. And at Hystelica, we've been collecting some kind of survey research over the coming years and over the previous years, and we're coming on to hopefully do some more experimental work to prove this further. But we already have good evidence. For instance, this study was published just a year ago that basically was able to do a systematic review of all of the animal studies that had taken place looking at psychedelic actions and biological sex. And if they looked across the different male and female animals that have been used, they did see that there were differences in the outcomes. But one of the most interesting thing, as I said, this isn't just about comparing males to females, is that when you actually find studies who took took the cycle phase or the hormonal phase of the animal into account on when they were dosing with various different substances. So here you can see some examples from MDMA, from psilocybin, and from LSD, that there are different reactions depending on which phase of which hormonal phase the animals were in. Now, this poster on the right-hand side was a poster done by one of my research assistants, Aline Frick, where we tried to look in the literature at where we could potentially find some clinical human data to see if this effect was there. And what we did here is we took two studies who had used MDMA in a clinical population, asking the same outcome questions. One had basically defined all of the females who took part in the trial to only be dosed during a high estrogen phase, and the other trial didn't bother to differentiate between these two. And what we saw is that in the outcomes of this, the variability in the group where females had not been defined by phase was much larger than that was seen when it was. So we really do see there is a difference. But we do not have enough insight. We do not have enough data to be able to really understand this. And there's a lot of reasons why women have been excluded and not properly investigated in clinical trials. And it's beyond me to regurgitate it every single time I speak. But we are in a position now where we do have the insight. We do have incredible female leaders sitting at the front of psychedelic teams now, which we didn't have. We've got incredible tech and various different evolutions in how we can track things like hormones in our saliva, for instance. And so it's now a case that we have to turn to our clinical trials and to our researchers and say that we need to understand if there are altered responses in women compared to men and between hormonal phases across a vast array of substances. So, for instance, the question, do ovarian profiles modulate psychedelic action? I think that's going to be vastly important when we think about personalizing any treatment protocols, and so we can ensure the safety for all women who take part in those trials and also the best possible outcomes. Now, we see that women's variable responses across menstrual or life stages highlight this huge need for this specific understanding between sex for any clinical trials. But I think it's also extremely important that it also comes into things like harm reduction and education. It's vital that we talk to women about how different substances, how their craving and use for different substances may change over the menstrual cycle, but also how their pharmacokinetics might change in relation to the drug, how their safety might change in relation to the drug. And it's not beyond us to be able to do this, but we just need to really take a fine lens on women and not just say women and men, but actually look specifically within women so we can see how these hormonal phases track up to their behaviors and their outcomes. I will leave it there. Thank you so much for allowing me to come and speak about this. As Joe mentioned at the start, I founded Hystelica as a research, educational, and advocacy organization so that we don't get women are not left behind again as we advance with psychedelic science. And I've been so lucky to meet incredible women and build incredible teams around me. So if you'd like to check out what we're doing, please see details currently on the screen. But otherwise, thank you very much.
Thank you so much. I see some thanks coming in there into the chat. Thank you so much, Grace. It's so great to have you, working on this. It's so needed and so important. And in all my career, it's been sorely lacking. This real understanding of stages of the menstrual cycle, levels of gonadal steroid hormones, changes in life stage of women and their impact, their response to drugs. Use, prenatal exposure, and long-term outcomes for mother-infant dyads. So thank you so much for coming to be with us today, Amanda.
Awesome. Thank you for having me. Hi, everyone. I have a slightly different accent that's way less fun than the rest of the panelists, but I'm joining you from Florida in the US, and happy to be here. So thank you, Grace, for that overview. My presentation is going to be much more social science focused, on substance use in pregnancy, what health consequences we see, and what evidence-based interventions we have. Of course, coming from the US, a lot of my presentation will be US based. I did pull some London data on a few points, but I'm not an expert in drug policy in London, so I'm not going to pretend to be. So today we're going to talk about the epidemiology of maternal substance use. So who and what, the impacts on maternal and infant health, and what evidence-based interventions we currently have in the US. So a few reasons why this topic is important. First, wanted to highlight those. Why it's imperative not only for maternal and child health, which is the area of research that I focus on, but ultimately population health. So the entire population comes from a mother. And so no matter what, pregnancy is ultimately the number one, to me, impact on population health. We all start as a fetus inside of biologically female. So some of these main reasons that drive my passion for this topic is that drug overdose is the number one cause of maternal mortality in Florida and many states in the US. So you can see the other causes being motor vehicle accidents, suicide, homicide, and then other. And so this includes pregnancy-associated deaths. This is during pregnancy and during the first year postpartum deaths. And you see the blue line being overdose, the highest. And it has been the highest since around 2018. This is true for a lot of states in the US. Most of those are driven by fentanyl and opioids. I did look up, my next slide is about London. So, or this is UK data. So, the data I could find for the UK on maternal mortality rates grouped drugs and alcohol causes as indirect psychiatric causes. So that's where this green arrow is. So it's roughly one of the top 4 causes of maternal mortality in the UK, with thrombosis being the highest in cardiac disease and COVID-19 being more common, but still one of the more common causes in the UK. One thing I wanted to add, sorry to go back to Florida and US data, is that the majority of these overdoses happen in the postpartum period. So pregnancy is a driver for behavior change. I'll mention that a few times. It's one of the most powerful drivers for behavior change at any time point in population health. But in the postpartum period, this is where most of our overdoses happen due to a lot of different reasons. We can think about sort of the biological reasons that Grace talked about. There's a lot of hormonal changes in the postpartum period that are quite complex, but also issues like continued access to treatment. It depends on the state in the US whether, for example, Medicaid is our one of our public insurance programs in the US, whether a woman has access to Medicaid through that whole first year postpartum, or if she loses access within 60 days of delivery. So access to treatment during the postpartum period is paramount, but also we can think about the additional stressors that are happening in the postpartum period. We have a brand new baby. Most of these are in the later postpartum, so mom probably went back to work, at least in the US. So a lot of social stressors that are playing into this, along with limitations on access to care and implications of hormonal fluctuations that are impacting current treatment that she's on. The other driving force for me in this topic is that in Florida, 72% of child protective service cases involve parental substance use. So it's by far the number one cause of child removals from their parents and them entering the foster care system or being adopted. The rates I found for London were 50 to 70% of cases of children that are removed from their parents are due to parental substance use. So it is similar, Florida versus London, and this is true in most states in the US. So, of course, this is not the outcome anybody wants. It's quite traumatic for both families, for both parents, and of course the child. And it creates this cycle of trauma for both. So it's actually been proven that once a child is removed, the mom has a much higher risk of overdose, returning to use, even if she's already in recovery and has been for the entire pregnancy up until that point. So you then have a mom at a higher risk of overdosing and dying. You now have a child who is entered foster care and had a very traumatic experience that they will carry with for them forever, that will then also increase their risk of using substances in the future and having mental health conditions. Another reason is that, so when we think about the hormonal fluctuations in biologically female people, birthing people spend about 40 years of their entire life either avoiding pregnancy or trying to become pregnant. So there's only two options, right? It's either get pregnant or don't get pregnant, and the cycle continues every month. And so when you think about females spending 40 years of their life doing one or the other, we can see why 50% of pregnancies in the US are unplanned. I don't know what that rate is for the UK, but in the US, it's about 50%. So we want to think about reducing exposures and substance use and improving health through what we call preconception health in women of reproductive age, because 50% of these pregnancies are unplanned. So ideally reducing those exposures before a person becomes pregnant, unplanned. And we know that most people don't know they're pregnant. The average in the US is around 6.5 weeks that somebody finds out they're pregnant. A lot of development, fetal development happens before 6 weeks, right? The major organs, the spine, the heart, all develop before somebody finds out they're pregnant around 6 weeks. Also, so when we think about stigma, and I'll talk about that a little bit, women generally do not choose to start using substances and drugs once they know they're pregnant. Those who can quit on their own usually do. And so this is our distinguishing factor between substance use and a substance use disorder. Most people, once they become pregnant, stop using substances. But if somebody has a substance use disorder, obviously that's not as easy of a change. And then, of course, when we think about drugs, we can think about somewhat of poison is in everything and no thing is without, but dosage makes either a poison or a remedy. So we can always think about dose when we think about substance exposure in pregnancy, although it's quite difficult to track that and look at outcomes differentially due to all of the limitations around including pregnant people in research. Okay, so what are some types of prenatal substance use? So marijuana by far is the most common illicit drug use among women. Of course, in the US, this is US data. Um, this is among women ages 12 and older in 2019 in the US. So 15% had used marijuana in the past year. 6% psychotherapeutic drugs. We see hallucinogens there at 1.5%. So by far, marijuana being the most common. But among pregnant people in the US, alcohol is actually the most common drug that was used. So this is among pregnant people aged 15 to 44, looking at substance use in the past month. And so 2020, the most common was alcohol at 10.6%, and then marijuana was about 8% for past month use. So I'm going to go through each substance one by one and talk about sort of the risk and what we see in the US in terms of prevalence. So among women of reproductive age, 56% use alcohol, 25% binge drink, which is 4 or more drinks within 2 hours. Of course, this increases the risk for dependence, tolerance, and addiction to alcohol. And alcohol use disorder among women is about 20% in their lifetime. So 20% of women have an alcohol use disorder in their lifetime. That's extremely high, 5% in the past year. So very common. And from the alcohol rates I looked at for UK data, it's actually a little bit higher in the UK alcohol use versus the US. Among pregnant people, 9% report using alcohol during pregnancy, 3% with binge drinking during pregnancy. And that 9% was actually, I found the same in London. So around 9 to 10% of pregnant people in London and Florida use alcohol during pregnancy. But it is one of the most toxic substances to use during pregnancy for the fetus because of things like fetal alcohol spectrum disorders and developmental disorders. So fetal alcohol spectrum disorder is a set of symptoms presented as a result of unknown amounts of alcohol exposure. So again, we can't give pregnant people alcohol or any drug and then follow them over time and see what happens. All we really have is observational data. But fetal alcohol spectrum disorder is associated with physical problems, behavior, and learning that are long-term. There's no treatment for FASD. And it can lead to quite severe learning disorders and behavioral disorders once children enter school years. The picture is some of the signs of fetal alcohol spectrum disorder. One telltale one is the sort of smooth philtrum, flat midface, small head, low nasal bridge, and the underdeveloped jaw. So some health outcomes of alcohol use during pregnancy include a higher risk of miscarriage, stillbirth, and poor nutrient absorption for the mom, for the baby, birth weight, craniofacial defects that I just showed, and ear placement disorders, and then also organ issues like the heart, kidney, also the bones, and issues with hearing. So alcohol, when I talk to a pediatrician who I work with often that really focuses on opioids a lot, he says alcohol scares him much more than opioids do in terms of prenatal use, because opioid exposure, we'll talk about a little bit, is less severe and more treatable. So then nicotine and tobacco. So thankfully, tobacco use has gone down in both areas over time. Of course, we know what's replacing that is vaping. But still, about 20% of women of reproductive age use tobacco. Of course, this leads to dependence and tolerance and addiction for some people. And pregnant people, it's gone down. So 16% in 2012 to 5% in 2021. And that's US data. This is data from England. The women's smoking status at time of delivery. So you can see this nice decrease over time, although we've got 6.6% of women in England reporting smoking at the time of delivery. So this is an indication, of course, that they smoked through all 3 trimesters, which would be the highest risk for poor outcomes for the baby. Um, and then just to mention, of course, what is driving a lot of the tobacco reduction is increases in things like e-cigarettes and vaping. Um, so I'm not sure which year of data this is from CDC, but 7% reported e-cigarettes around the time of pregnancy, 1% during the last 3 months of pregnancy. Um, and some outcomes from tobacco for the mom, it can lead to placental abnormalities and changes, which of course the placenta is what provides the baby all of the nutrients and oxygen that it needs, and supports the fetus's health through the whole pregnancy. For infants, tobacco is a higher risk of small for gestational age, preterm birth, and sudden unexplained infant death syndrome, or SUIDS. For children, it leads to things like asthma, can impact lung function, and infants that are exposed to tobacco in utero actually have withdrawal signs at birth, similar to opioids. And so it's been found that infants that are exposed to both tobacco and opioids in utero at the same time often have much more severe withdrawal signs than opioids alone. So marijuana, as I showed, is a very common substance that many people use. In females 12 and older, was 17% past year, 11% past month use. Of course, there's a risk for things like marijuana use disorder that we're learning a lot more about. Previously, there was a lot of talk that marijuana was not addictive. We know now that it definitely is, and there's now diagnostic criteria for marijuana use disorder. So this is the most common type of substance use among pregnant people in the US. And so 12% use marijuana during the first trimester and then 17% overall. In the US, we have some odd patchwork of policies around marijuana, with some states having completely legal recreational marijuana and some states having a combination of that and medical marijuana, with extremely limited oversight on selling of marijuana products to pregnant people. Even here in Florida, we only have medical marijuana. There's no very clear policy about what a medical marijuana clinic should do if somebody comes in, obviously pregnant, and asks for medical marijuana. There's no policy on what kind of information they should provide to the woman, or guidance on the risks and benefits of marijuana during pregnancy. So this is daily or almost daily marijuana use among women 15 to 44 by pregnancy status. So the left side is pregnant. So 3% using daily or almost daily during pregnancy in 2020, versus about 5% of non-pregnant women. So not a huge difference between the two groups by pregnancy. So some health outcomes that we've learned, thanks to the patchwork of policies in the US, in the states that have legal marijuana, it's much easier to do research now and look at outcomes. So we know that it can reduce prolactin hormones during breastfeeding. Marijuana does transfer through breast milk, and can last in the breast milk for up to a week, depending on how the marijuana is used, ingestion versus inhaling. For infants, exposure can lead to preterm birth, kind of similar risks of tobacco, of marijuana use during pregnancy. So preterm birth, low birth weight. It's been shown to affect gross motor development, and the long-term effects of marijuana exposure in utero are unknown. Opioids are where a lot of my research began. I grew up in Kentucky, which is was one of the states highly affected by the opioid epidemic in the U.S. So females 12 and older, 28% opioid in the last year, 3% prescription misuse, meaning using an opioid prescription it's not prescribed. So using somebody else's, taking more than is prescribed. Saving an old prescription and taking it at a different time. All of those are examples of prescription misuse. Of course, opioids have a very high risk for dependence, intolerance, and addiction. Among pregnant people, 7% use a prescription opioid, and Florida data is about 1% of mothers have an opioid use disorder at delivery. So risk for fetal outcomes include neonatal opioid withdrawal syndrome, which is withdrawal after the baby's born, preterm birth, and some developmental abnormalities. Importantly, for opioids, I mentioned is overdose is the number one cause of maternal mortality in Florida. Opioids are driving that, and really the fentanyl um, infiltration of the illicit drug supply is driving the overdose crisis in the U.S. still. So neonatal abstinence syndrome, also known as neonatal opioid withdrawal syndrome, are symptoms that show up after the baby is born, after exposure to opioids in utero. The baby has this high-pitched cry, excessive crying, poor sleep, hypertonia, tremors, and GI issues. So overall, they end up requiring higher levels of care, often are hospitalized for longer lengths of stay. Um, Although care, at least in the US, for infants with NAS and NOWS has improved, and so some of those outcomes are getting better. Previously, infants were often treated with morphine and methadone to combat the withdrawal symptoms that they had. So essentially, the infant was exposed to opioids. They're born, they no longer have that exposure from their mom, and so then they start having withdrawal signs like an adult would that stopped using opioids. So they're quite severe, but they are more short term and can be treated. There are some studies suggesting developmental abnormalities, but again, the developmental abnormalities of alcohol are actually much more severe than those of opioid exposure during pregnancy. Um, this is just showing over time maternal opioid use at delivery. So this is Florida data. So you can see the red line is maternal opioid use looking at 2000 to 2019. So you see this huge increase from 2000 to 2010. So this is in Florida, but this mirrors national data. Essentially, when opioids were way overprescribed in the US, when large pharmaceutical companies were pushing that opioids were not addictive, when they in fact definitely are. And so it incentivized clinicians to prescribe a lot of opioids at very high doses. And so we saw this huge increase in overdoses and what became the opioid crisis in the US. So of course that affected women and mothers. And so we see this huge increase, but even around 2016, and this goes to 2019, these decreases, most of which are not statistically significant. So we've seen a plateau of opioid use disorders in the US rather than like a nice decrease. So health outcomes I mentioned, but for the mom, overdose being the number one concern, it can also lead to preterm labor. Methamphetamine or amphetamines. So these are actually becoming more common in a lot of areas in the U.S. So among females 12 and older, 5% have used methamphetamine in their life, 1% in the last year. Has a very high risk of addiction, similar to fentanyl. Pregnant people, 0.7 to up to 5% in endemic areas. So some states, researchers I've talked to in the US have up to 5% of methamphetamine use during pregnancy. And some fetal risks include fetal growth restriction and low birth weight. I think, one of the drivers of this change from heroin to other opioids to methamphetamine is the infiltration of fentanyl in our drug supply in the US. So some people are changing from opioids to methamphetamine to try to avoid overdosing from fentanyl. But data from our medical examiner's office and others show that pretty much all of the illicit drug supply in the US contains some level of fentanyl, including methamphetamine. So methamphetamine increases the risk of hypertension, placenta previa, and placental abruption among moms during pregnancy. For the infants, I mentioned growth restrictions, and then there are developmental issues and behavioral issues among infants after exposure. One main issue with methamphetamines is that there is no currently an FDA-approved treatment for methamphetamine use disorder. So we have medications for opioid use disorder. We don't have any for meth. So psychedelics, this is an area where I've met Grace and an ongoing area of research due to all of the limits of research. So thinking about women of reproductive age, 13% psychedelic use in their lifetime, 2% in the last year, with an 8% lifetime use of psilocybin. The risk of addiction depends on other substances. There's really a very low risk of addiction for psilocybin. There has been some studies showing that ketamine has a risk of addiction higher than other psychedelics, but this is still ongoing. But in general, it is a lower risk than like opioids or meth. Pregnant people prevalence is a question mark, at least in the U.S. right now. This is just showing the number of seizures in the U.S. of shrooms or psilocybin-containing mushrooms as an indicator of an increased use over time in the U.S. So you can kind of see this nice from 2017 to 2022. And then this is just the hallucinogen use among women of reproductive age of 1.5%. Has increased significantly over time. The last time I saw the NSDUH National Survey of Drug Use and Health, it's trailing behind marijuana now. So health outcomes, there's extremely limited data. This is one area that I've been working to get more data on risks and benefits for moms. So we know that moms and women are starting to use psychedelics more, but we don't have any data to tell them whether it's safe or not. And so they're really seeing one side of the story on social media of all the benefits of psychedelics. And certainly some of those have been shown in clinical trials, but also they need both sides of the story. We do know that psychedelics can be transferred through the placenta and breast milk, so they do transfer to the fetus. And then there is a concern that in the US, that we have 2 states that have changed policies around psychedelics, but the rest of the states, they are illegal. So you have to think about things like child welfare involvement, as well as child safety when someone's taking large doses of psychedelics. One of the main issues really is that most people don't use one type of drug. Really, polysubstance use is the norm during pregnancy and in general for substance use. 39% reported polysubstance use among people who use alcohol during pregnancy. So about 40% of people who use alcohol were using another substance during pregnancy as well. 89% polysubstance use among people who used opioids during pregnancy. So about 90%. And then 74% used tobacco that also used marijuana. So we have a combination of exposures that, of course, increases the risk, but also makes it extremely difficult to determine outcomes based on specific exposures, because it's much more the norm, as you can see, that people use more than one. So teasing out which drug caused which outcome is quite difficult. So we can skip this. The other thing I wanted to mention is that, like psychedelics, as substances hit the market or are unregulated and enter the illicit drug stream, research cannot keep up with as fast as new drugs come into the market and come into the, especially the legal market. So things like kratom is becoming quite popular in the US. I don't know if that's a thing over there yet, but there's all these like kratom cafes that you can go to and get it. And there's no data on the safety of that. So it's kind of the Wild West that you're just choosing to go use something that has absolutely no research on the safety of it. So just because something is sort of marketed as natural doesn't necessarily mean that it's safe. So some interventions for prenatal substance use, I wanted to highlight what not to do first. So first, criminalization of prenatal drug use is associated with adverse outcomes. It does not lead to less substance use. It leads to harmful outcomes for moms and babies. This is just showing differences in laws in the US by punitive criminal drug use. So like some states count it as child abuse, substance use during pregnancy whatsoever. Some states will just automatically take your child away if you have signs of substance use at pregnancy or delivery. Other states will terminate parental rights. Other states will charge you as criminal negligence and throw you in jail. So it really depends on the state, but all of which do not lead to great outcomes. They lead to decreased maternal substance use treatment, enrollment, and continuation. So moms are less likely to disclose they have a substance use because they don't want to lose their children, rightfully so. It decreases maternal psychosocial services, late initiation, and decreased prenatal care. So moms are not wanting to go to the doctor because they're scared of them finding out that they have a substance use disorder. Increases in stillbirth and infant death, increased foster care placement, and decreased parental unification rates. So those are the rates of like the parents getting their child back after they're removed from their care. All of those are associated with punitive state laws. Also, there's evidence showing that overdose rates increase as drug confiscation rates increase. So as more drugs are taken from people off the streets, they then start to withdraw. They go to find their drugs from somebody else, maybe a source that isn't quite as safe, they don't know as well, which then increases their risk of overdose. So there is data showing the more drugs that are taken by police from people, the more overdoses that happen in that community. So taking them away doesn't actually solve any problems. Oh, sorry, this like moved weirdly. Okay. Also in the US, depending on the state that you're in, some states use screening for substance use, universal screening at delivery. Some of them will call it like risk-based screening. So this mom has a risk for substance use based on some screening tool. We're going to drug screen her at her delivery. These results have pretty low sensitivity and specificity depending on the drug. So opioids actually clear your system within about 24 to 48 hours. So unless somebody has used an opioid in the last day or two, it's not going to show up on a drug screen. Marijuana is the one substance that stays in your system for about 30 days. So that one will show up. But this practice is associated with the avoidance of hospital births. So people try to give birth at home, which can be quite risky depending on the resources that you have, and fear of CPS involvement or child protective services. There's also clinician bias in which moms that are drug screened, Black moms are more likely to be drug screened, as well as moms with lower socioeconomic status. Um, so, so what should we do? Sorry, this like keeps moving. This is really odd. Okay, what should we do? So we know that addiction is a treatable chronic medical disease that involves complex interactions among our brain circuits, genetics, and the environment. It's a chronic condition, not a moral failing, so it is treatable. Our evidence-based interventions we use in the US, although need much improvement, including the screening, brief intervention, and referral to treatment, or what we call SBIRT, which is essentially just a model of how to implement screening and referral to treatment in the US. It can be used in any setting, and there are reimbursement systems set up to do SBIRT. It can be done in the clinical setting, but also in community settings to identify early substance use disorders and refer people to treatment. We have medication therapy for substance use disorders. Specifically for opioid use disorder, we have methadone and buprenorphine. They do lower the risk for adverse fetal outcomes, although they do still cause withdrawal among the infant after they're born. There is some safety data on medications for opioid use disorder and nicotine use disorder, but they're extremely limited. We have things like nicotine replacement therapy that can reduce the risk, like the patch or gum. And I mentioned there's no approved medications for stimulant use disorders. So that's a tricky one as use of methamphetamine goes up. Other evidence-based interventions include harm reduction. So this is a practical transformational approach to empower people who use drugs to improve their health without stigma or shame. Sadly, in the US, it's kind of controversial depending on what state you live in. So this is engaging people who use drugs to prevent overdose, prevent infectious disease transmission, lower barriers for healthcare services. So connecting them to counseling and treatment, providing supplies like naloxone, which is an overdose reversal drug, fentanyl testing strips, needle exchange, condoms, medication lockboxes, even just like wellness kits with deodorant, with baby wipes, things like that. So meeting people where they're at, offering them the help that they're willing to take, and then just being there in a non-shameful, non-stigmatizing way. For harm reduction in pregnancy, I mentioned universal drug screening and criminalization just leads to barriers to prenatal care and barriers to treatment for moms. Treatment goals may include reducing the amount of substances or the number of substances during pregnancy, right? So, if a mom is using marijuana and tobacco, can we get her to stop using marijuana, right? And then she only has one substance exposure for the baby. So, harm reduction for pregnant people can include just reducing the amount also. So, she smokes a pack a day of cigarettes. Can we get her to smoke half a pack a day? That would be a harm reduction approach to people using substances during pregnancy. Also, getting someone to prenatal care, even though they're using substances. So, getting someone in for blood pressure screening, to check them for a UTI, to check them for infectious diseases, even while they're still using substances, is going to reduce the risk of adverse outcomes for babies and moms during pregnancy. So, meeting people where they're at, even though they're pregnant, weighing both mom and baby outcomes. Then we can think about trauma informed care. So, making sure that people feel seen and heard and in control of their clinical care and of their life. Most people have, most women actually have much higher rates of trauma and violence histories, which lead to higher risk of substance use and mental health conditions and all of these things. So, really, we should be approaching almost anybody from a trauma informed lens. And then reducing stigma. So language matters instead of addict or user or junkie. It's a person with a substance use disorder. So using first person language. And a baby that was born addicted, we don't say that. We say a newborn with drug withdrawal, to reduce some of that stigma and take down barriers. So this is just a table showing like differences in language. So we don't really want to use like abuser, junkie, those sort of things. There is like a Words Matter pledge that Johns Hopkins came out about pledging to treat all people with substance use disorders with dignity and respect, and talking about it as a chronic illness, not a moral failing. What else? Oh, as healthcare clinicians, there is a lot of bias and still a lot of stigma around substance use disorders in the medical community. But as clinicians, they're supposed to, they take an oath to do no harm. And ultimately, treating people with substance use disorders with stigma and judgment is doing harm. And this is just an example of all the levels that stigma affects a pregnant person. So we can think about this on the individual level. A newly pregnant person believes they're a bad person because they use illegal substances, so they don't seek out prenatal care. So that's sort of like internal shaming. Interpersonal, a newly pregnant person who uses drugs loses previously supported friends or partners who may not also use drugs, leading to isolation and depression and an increased risk of overdose. So family members are upset this person won't stop using drugs even though they just found out they're pregnant. Then cutting them off and just increasing their risk of adverse outcomes. Organizationally, a healthcare institution obtains a urine drug screen of a newly pregnant person without their consent. So some healthcare systems do this in the US, where they do universal screening. They don't really tell you. You always do a urine test when you go in for a prenatal visit because they're checking for UTIs, but they could just run a drug screen panel without telling you in some states. So then they notify child welfare services or protective services. And end result, the pregnant person loses trust in their new medical care provider and no longer goes back to prenatal care. In the community, a substance use treatment facility does not offer a pregnant person evidence-based medication. So there's a lot of limits on access to treatment among pregnant people in the US, especially in Florida, and for specific medications due to a whole slew of reasons. Okay, that's all for me. I'm happy to take any questions at the end.
That's great. Thank you very much, Amanda. So much information there. It's absolutely phenomenal. And once again, alcohol wins the prize for being the worst drug.
And socially, a lot of people are, you'll hear like grandmas and mas that are like, oh, one glass of wine is not an issue during pregnancy. It's kind of alcohol is very much a social, construct, of course.
Yeah.
But really any level of alcohol is not safe. And like the mommy wine culture, at least in the US, is a big thing. So
Yeah. And when I was pregnant, it was hard to sort of get sensible advice from clinicians, about this. There is a question for you here about drugs in the US being contaminated with fentanyl. Are they all contaminated with fentanyl?
most of the our medical examiner data, like that looks at overdoses
Yeah.
or fatal overdoses, most of those contain more than one drug, including fentanyl. So it's never like a pure methamphetamine, a pure cocaine. There's fentanyl in the cocaine system. There's fentanyl in the MDMA pills. In pretty much any drug that you buy on the illegal market in the US, there's a risk. There's a lot of overdoses among young people that are
Mm.
taking what they think is an MDMA pill that contains fentanyl.
We have similar in the UK with nitazines, don't we? And yeah, Karenza's the expert for that. Wow, thank you. Do post your questions in the Q&A, everybody. Thank you so much, Amanda. Absolutely phenomenal wealth of information there. Absolutely fantastic. So I think we'll move on then to our third speaker, and then if everybody gets their questions in the chat, then we'll have the discussion. So Dr. Karenza Moore is a reader in sociology at Newcastle Uni here in the UK. She has been working on illegal drug use laws, policies for a long time now, for over 20 years. She's, one of our main experts. She focuses on young people's illicit drug use in recreational spaces, such as raves, nightclubs, festivals, after parties. And we've done a podcast with her for Drug Science on drug use at after parties. That's really good, folks. I would
Yeah, with
highly
Lisa
recommend.
Williams. Yeah.
Oh yeah, with Lisa Williams. Highly recommend. Yeah, that's so cool. So her most recent projects were on post-pandemic youth ketamine use in the UK and in Europe, and on queering the rave as important spaces of self-expression for trans and queer women of colour in the UK. Thank you so much for being with us today, Karenza. It's great to have
Thanks.
you.
Thanks for inviting me, and thanks to Grace and Amanda for some really interesting work. So it's going to be a bit of a shift, but I was noting down quite a lot of a kind of linking between our presentations, particularly around women and harm reduction. Actually, I thought that was a really interesting link. So I'm actually I've got 10 slides, and I will try and remain brief because I really want to hear people's questions about this. But so I'm going to, sorry, I'm not sure why I haven't got the full screen on, but I'm just going to accept that. So I'm going to talk very briefly about sex, gender and drugs and the kind of space that I'm working in as a social scientist, fellow social scientist Amanda. And then I'm going to talk a little bit about some work that we did post-pandemic about trans women's drug use, and in particular, as you said, Joe, how raves might work as a kind of space for self-expression as trans women kind of transitioning, and also in relation to kind of hormonal issues, trans women's hormonal issues and drug use. Then talk very briefly about women who rave, and again, it's interesting we're talking about MDMA and overdose and drug-related deaths. And I know you've got the next street drug discussions on that, so that's really interesting. I'm going to focus very briefly on that. And then another little bit of work that I do actually that is kind of coming a little bit more into what I'm interested in is about young women in the global south, what we might call the majority world, because the majority of young people actually live in the global south, and some of the kind of amazing drug harm reduction work that's there. So I thought that would be a good thing to kind of flag when we're thinking of in a global perspective. And then I'm going to chuck in a bit of theory at the end, just thinking a little bit about this fantastic phrase, which I love, called narcofeminism, and kind of thinking about how we can kind of rethink women's drug use more generally. Okay. So, I am obviously kind of working in a space because of my research around trans women, and I'm sure you know all the kind of goings on in the UK around trans women. What I'm working with is a kind of non-biological or non-essentialist position in relation to what I might call female. And I'm trying not to kind of reduce this experience to a binarized biological sex in the kind of social sense, I guess. So one of the issues is that we can't kind of categorize, or scientific consensus acknowledges that there's a kind of combination of different traits. They could be categorized in various different ways. And actually, one of the issues is that doesn't particularly fit into kind of linear scale from male to female. And particularly in the UK, and I know the same is in the US, there's a kind of real populist, public, legal discourse which really kind of ignores this. And, we've seen transphobia really kind of spreading over the last 10, 15. I mean, it's always been there, but it's kind of got a lot worse for trans women, particularly trans women and transgender people more generally. The other thing which I think is kind of important and to think about is the way that the divisions of sex were actually, in terms of their history, part of the kind of Western colonial project that controlled colonized peoples in the global south. And it's important to kind of think about that context. And I'll say a little bit about global south later on. Again, thinking about the context, and I think this is really important. I thought it was interesting, Grace, where you were saying about the kind of medical, biological, and then the psychological and social sort of overlaps, and those three overlaps. I think this is a kind of really important space to think about. And I think it kind of needs people that are far more knowledgeable about the kind of biological aspects of drug use, but also the kind of more social aspects. So when we were talking about or thinking about this work around trans women's drug use experience, particularly in relation to how they transition, when they transition, thinking a lot about the kind of social context and the care that is and isn't given to particularly young transgender people. And I've just focused on the UK here because obviously we've only got so much time, and that's where my research kind of is situated. So if we're thinking about, say, minority stress theory, or thinking about the kind of difficulties of engaging with the care system as a transgender person, and how managing that kind of those difficulties will sometimes result in alcohol and drug use. And we know that queer people in the LGBTQ plus community do have higher rates of alcohol and drug use, and may be more likely to develop problems with alcohol and drugs than their kind of straight peers. So I think that's important to flag. What we see is, again, I was interested to hear about the kind of what you were saying, Amanda, about trauma-informed care and interventions, because this is something that really doesn't happen for trans people, particularly young people. And so we're kind of in this really difficult space where there's been some withdrawal of care as well. There's been, on the kind of maybe more positive side, a kind of long history, and I know this is the case in the US as well as in the UK, of really excellent interdisciplinary research, which kind of examines some of the issues that transgender people face. And again, I think we can think about this in terms of, say, alcohol and drug use treatment. For particularly, shaping it and making these services kind of inclusive, I guess, for transgender and intersex people as well, who often kind of face, we know they face the oppression, segregation, so that's happening in the UK at the moment, discrimination and human rights violations. And so this is the context, a really mixed picture that we undertook the research on trans women's experiences of illegal drug use, particularly situated within the rave as well. And that was something I'm kind of interested. The chapter's just out, so I think it's at the 25th. It's out tomorrow, so I'm very excited about that. So chapter out tomorrow. Looking particularly at this issue, but more from an intersectional position as well. So hopefully that will be of interest to people. So this was actually the first ethnographic study of trans women's experience, a younger trans women's experience, so under 40, depending on how we define youth. So young people's trans women experience of this kind of idea of obviously a social and medical transition. What's it like to go raving when transitioning whilst raving, or vice versa, and also this issue around taking recreational drugs. Particularly kind of interestingly for trans women because of the kind of hormonal profiles. Obviously, trans women will be prescribed hormones. Uh, uh, that's the kind of medical aspect of their transition, I guess. So it's really kind of important to be thinking about that. And I actually, one of the things that's kind of been talked about a lot, and this is anecdotal evidence really, because there isn't the studies about it, but for trans women, when they're medically transitioning, there might be an issue around the impact on serotonin availability, and kind of what happens as a woman taking hormones, much as we might be doing in our kind of menopausal phase of life. And how does that kind of shape trans women's drug experiences? And that is kind of problematic, because there is kind of reports about how MDMA particularly, going through transition, MDMA particularly affects young trans women. So that's something I think that we need to kind of look out for. Anyway, so we did the ethnographic study, which involves going to lots of different raves and parties, interviewing trans women, and particularly focusing on this kind of ethnographic way of researching this issue. And so we kind of created vignettes that try to explore particular kind of raves and how what is it like to transition in that space, take recreational drugs, and be able to express oneself in a way that maybe isn't possible within kind of everyday public spaces, as you might expect, particularly given the context I just mentioned. So what we kind of concluded was that actually, if we're thinking about this idea of queer in the rave, and kind of destigmatizing and decriminalizing drug use. And a lot of you that know my work will know that I'm an anti-prohibitionist, so that was part of the context of this study as well. And that in terms of social justice for intersectional groups, particularly on queer people, trans people, and trans people of colour, that these are really interesting spaces. I mean, we know that they're stigmatized. We know there's a lot of focus on kind of criminalization of law enforcement, but also they're very joyful spaces, for a lot of young people in the world, really, also in the UK. So I think this is kind of important space to be thinking about some of these issues. Okay, so I guess more focusing on sex and gender, and thinking about gender more specifically, and thinking about the way that alcohol and drugs are kind of gendered. So, in a sense, doing drugs does involve gender, and I think we've kind of seen this from the previous speakers. But there's also thinking about that beyond gender. So, an intersectional approach brings in things like race. I thought it's interesting what Amanda was saying about Black women being more subject to certain kind of tests during pregnancy. So, this issue is kind of speaks to recreational drug users as well as kind of problematic drug users, women as well. And I think, I was thinking about the way that alcohol, drugs are kind of represented, and this is not my idea. There's been lots of work on this idea of certain substances or ways of taking substances as being kind of masculinized and or feminized as well. And I think you can see that with alcohol in particular. So I don't know if you have this in the US, Amanda, but we've got this kind of phenomenon called a bottomless brunch. And it's so interesting the way it's kind of marketed at women. And I just grabbed a few images here, and as you can see, it's this idea of gender kind of shaping the patterns of modes of use, particularly, but also how certain substances are gendered, and whether or not that changes women's engagement with them in that sense. So why does this matter? I would suggest, and I think this also fits with our other speakers as well. So really, because of the underrepresentation of women in research around recreational drug use or drug use more generally, that there really is an issue of first of all, kind of not necessarily knowing in the kind of biological space about this issue, but also, and again, I know Grace mentioned harm reduction education. I mean, I personally think that we need a harm reduction education campaigns aimed specifically at young women. There was some two awful incidences the last couple of weeks in Manchester, the great city of Manchester, and that involved young women who passed away having taken MDMA. There's an issue around dosing here as well, which has been flagged up. This is really a kind of difficult issue. So, the one of the kind of things I think it's important to think about is because of global drug prohibition, we're in a space where, again, with fentanyl in the US, drug supply, people do not know what's in the substances. Drug testing in this country is still very limited. And so we end up having to kind of move into the harm reduction space in the more general context of prohibition. And as I said, I think this is my kind of personal take that we need a harm reduction campaign aimed at women who take drugs in these settings, particularly kind of going beyond the nighttime economy and festivals, although obviously they're very important, but going into kind of domestic spaces. And it's kind of interesting how the women are often associated with this sort of domestic space. And that's a really important space for harm reduction, thinking about, at least in my research, student halls, students particularly vulnerable in this case, house parties and after parties, which, I've already mentioned before. And they're focused on kind of divergence in terms of dosing and safety for women as well. And this, for me, relates also to the fact that many trans women in the UK DIY because of the gaps in services. And so hormonal changes are often not very mapped very well. And also for aging women as well, in the kind of perimenopausal space as well, that's also particularly important. And I know this, we've talked about this in a second. Over the summer, I did lots and lots of presentations about the youth ketamine research that I did. And one of the things that came out very much was young women's lived experience of ketamine dependency. And there were quite a lot of, some really kind of emotional testimonies about how young women had taken up ketamine in relation to attending raves. During the pandemic, when raving was shut, they became very kind of focused, on their own at home, and that's when their problems started with ketamine. And so I thought that was a really important thing to think about. And also thinking about young women with ketamine dependency and some of the issues, physical issues that emerge. For example, low body weight and urinary tract infections, but that actually, that there's an issue about what is normal for women's bodies, and obviously being slim is kind of very much valued rightly or wrongly in our society. So that's a kind of another issue that's emerged. So I mean, most of my work focuses on Western context in the UK, but there's kind of been some really interesting work coming out of the global South around young women's involvement in drug harm reduction initiatives, and so this is kind of very exciting space for me. I'm not going to say too much about it, but one of the things I think might be interesting to think about is how can we kind of move beyond understandings of youth and understandings of women as well, beyond a kind of deficit model, and think about all these fantastic resources that we have as women, the strengths that we have, and being able to kind of build on those strengths. We're here collaborating, setting up amazing initiatives, and that's something that's really happening in the global South as well. So I'd like to kind of say that this is a really positive trend, I think, that we're seeing in that space. And then that kind of brings us to, I guess, a more theoretical overview of where we are all really now. Thinking about what some fantastic researchers talk about, this idea of narcofeminism or revision in women's drug use. And so for those of us that have been in this space for a long time, you'll remember this corresponds with Elizabeth Ettore's call for revision in women and drug use. The term narcofeminism was actually coined in relation to women's rights in development, which kind of links back to some of the issues around young women's drug use in the global south as well. And this kind of idea that because of global prohibition, women are particularly kind of vulnerable and often experience some of the kind of most difficult trends and experiences because of that. So, as it says there, due to some of the punitive policies, women have these kind of really negative experiences around drugs and alcohol in particular. And so this kind of idea of narco-feminism really asks us to kind of center women who use drugs, center their stories, share their stories as well, disrupt some of the narratives that we have around women's drug use, and then, as I said, kind of have this real focus going forward on social justice for all women who take drugs. Okay, thanks, guys.
Brilliant. Thank you so much, Karenza. Absolutely brilliant as per. Yeah, disrupt the narratives about lots of aspects of women. I think that's really, really good. I was just thinking about trans women and the massive hormonal changes, and especially if you're having to do it yourself. It's hard enough for non-trans women, but it must be so
Yeah,
hard and then so dangerous, actually, because we've
yeah,
heard.
it can be. But I think, well, it's interesting you say that, Joe, because there are kind of communities of trans women who support each other in their DIY. So there's medically trained trans women who will be giving advice. But again, obviously, this is all underground, and it relates, as I said, to the lack of services in the UK, or withdrawal of care, or huge waiting lists. I mean, you might have
Yeah,
seen in a report recently
yeah,
about those waiting lists. I mean, there's been a puberty blocker ban on up for under 18s in this country as well, initiated by the Labour government. So young trans people under the age of 18 are pretty much not getting any medical help at this point. And then that opens up a space for DIY.
absolutely.
Yeah,
Yeah.
so that's very concerning. But yeah,
It is shocking,
yeah.
actually, absolutely terrible. Now, Daphne is commenting in the chat. The term we coined when I was Euro NPUD chair, oh no, don't lose this, and created the sister WD because of women,
Mm.
gender, non-binary people were rare at our meetings and actually not represented. And in 2019, she was the only woman at meetings.
Thanks, Daphne. Wow, that's really
Mm,
interesting.
Really, really
Yeah,
interesting.
yeah.
Yeah. Yeah. Trans people have communities have survived in supporting one another
Yeah,
online, and good for
yeah,
them.
exactly. Yeah, thank you, Natasha.
And I
Yeah,
suppose lots of drug users support each other online as well. There's a lot
yeah,
of that,
exactly. So
isn't there?
there's a kind of intersection there, I think,
Yeah,
particularly around estrogen and hormones and
yeah.
hormonal treatment. Thank you.
Yeah, it's really, really interesting. Oh yeah, Nicola says in Glasgow, lower drug deaths because of people supporting each other and peer support, and we've seen this in so many aspects of all this. People supporting each other. That peer support is absolutely essential, isn't it? And so powerful. Um, yeah, okay, so I don't know, have we got a bit of a shy audience? But you only have to type your question in, and there's no such thing as a silly question.
I can see, Joe, I can see one right at the bottom here from anonymous attendee.
Yeah, about Slim. Yeah.
Yeah. Then manage overdose scenarios in line with pop culture. Yeah, that's really interesting. I think more generally, I mentioned about the 2 drug-related deaths in Manchester, both young women, both students. And one of the things that came out of one of the things that was said on the alert, the alert was from Mandrake, which, if any one of you knows, there's a kind of drug testing lab in Manchester, does loads of really good work around harm reduction. And there was some kind of information about dosing, which I thought was really interesting, going from the kind of light dose of 30 milligrams of MDMA, really light, right through to 100 milligrams and seen as a heavy dose. And also we've got this issue of super strength, high purity supply of MDMA and ketamine, high strength pills. But one of the kind of issues is, and I don't know, actually, this is probably a question for Grace and Amanda about in terms of dosing and the
Yeah.
difference between men and women and body type, women's body types as well, which is a really interesting point. And yeah, whether or not that's something we can talk about in relation to overdose and overdose prevention as well. Yeah.
I think it is absolutely very, very important. Yeah, yeah, yeah. And if you actually think of people on ADHD medications, on Monjaro, and people losing weight and then dose. I mean, we always say start low and go slow. Grace?
Yeah.
Yeah, and even just thinking about how as you say, our hormones kind of change our pharmacokinetics with different drugs, and particularly when we look at something like MDMA, a lot of MDMA, I don't know about these cases that you're talking about, exactly what the cause of death was, but often it can be to do with essentially people overhydrating and the salt levels within their blood essentially being too low, and that is what can then lead to people dying. Now, when we see across the hormonal landscape, our bodies naturally retain water at different levels at different times in our menstrual cycle. So, for instance, when people are in more late luteal phases and they're taking MDMA, they could be at a heightened risk for overconsumption of water, which can then obviously lead to huge issues with having low sodium, like, nausea and headaches, but, right up to like seizures and coma. So it's not even just a case of, perhaps body weight in women being different from men, or having lost a lot of weight, having more of an effect from the drug, but actually as our hormones fluctuate, our body is breaking down the drug at a different rate, but it's also holding on to fluid at a different rate. So we were at more of a risk at different cycle phases.
I didn't
So
know that at all.
I I didn't know that.
Yeah,
either.
and it's it's something that has been reasonably well sort of characterized in terms of the difference in female effects to MDMA, and it isn't something that I've often seen talked about. I think it's really important that we are really open about how we talk about women. I think
Yeah.
it's amazing that we look at how we can be inclusive, and how we can look at how transgender communities are being heard, and that obviously the implications of their hormonal treatments might be having on their
Yeah.
drugs. But I've seen cases where people won't tell women that there is a difference in them between men and women, because they're scared, that they don't want to seem like they're being exclusionary. But it comes at the risk of women who then don't have the information to arm themselves, to understand that you're not going to have the metabolism of that 6-foot rugby player standing next to you who you're sharing a pill with, right?
Yeah.
Number one, but also the way that you're going to be affected by the drug changes. I won't reveal too much about my own personal life, but I've seen a number of times where I've been at raves, and you find women who are really not in a good way, and you kind of say, what's up, and then they kind of say, well, I've just taken the normal amount of what I would do. And then you speak to them and they are like, oh, but actually I just started my period today, or whatever. And you're like, okay, well, right, let's get you some, get you some, more like, get you something to eat a little bit, get you sat down, kind of get you regulated, because their body is not regulating them as well as it did at the party 2 weeks ago.
Yeah,
Yeah,
oh,
yeah,
that's
yeah.
so interesting. I was just thinking as well. I think there's at least in the rave scene, I think there's a bit of a stereotype that it's the lads that are pushing each other, and there's this kind of having, let's get smashed kind of culture. But women can be like that too.
Yeah,
And I think there is sometimes this kind of assumption, I'm not really sure where it comes from, but that women are kind of, automatically going to either look after themselves or look after each other. And I do think that they do, and they do try. But actually, I do think we need to acknowledge that there is that kind of will to party as well among I don't know how to put it, but among
yeah,
women
yeah,
as there are men. And actually, interestingly, in terms of like MDMA use at raves, there's quite a lot of evidence that the gender disparity between actually in the space, the gender disparity between MDMA use is actually not that big. Not I only know that in terms of relation to prevalence, or how many of the women at a rave compared to men will be taking MDMA, and it's actually pretty similar.
wow.
So we really do need to kind of think about bespoke harm reduction for women, and I know that's something
Yeah.
that you guys also think. But yeah,
Yeah. And thinking about the massive hormonal changes that you have in pregnancy,
yeah,
huge. And
Right.
then postpartum, woof, everything just drops.
Mm-hmm. Yeah. I hope I'm not freezing. Yeah, I'm not a biological scientist, so I'm kind of learning too. I mean, one drug that I know has major metabolic differences is alcohol. So men actually have higher levels of alcohol dehydrogenase, which is what metabolizes alcohol. So it's just one of the reasons, aside from weight and body composition, that women are more affected by alcohol and they break down alcohol slower than men. So when you think about using alcohol plus MDMA or alcohol plus another drug, that can be one thing to think about in terms of overdose risk. But it's really interesting to think about menstrual phase impacts on overdose and risk taking behaviors to me. Yeah.
Yeah,
And
I know we had that question earlier that asked about,
yeah,
accident, overdose, and menstrual cycle. From what I know, unless Amanda, you know otherwise, I don't know if there's any specific data that really has linked, phases to increase in amount of overdoses. But if we just take the two facts that we have a change in metabolism for how fast our body is breaking down, absorbing and breaking down the painkiller that we are taking, and we have a change in symptom in that you've got an increased perceived pain during the latter parts of the menstrual cycle. Those two things combined, in my mind, would put people at a greater risk, that they're more likely to need more drug at a certain time of the menstrual cycle. And that could be coinciding with a time when their metabolism is perhaps not clearing the drug as fast from their body.
That's very interesting. Yeah, I do know that so during pregnancy, for example, like medication for opioid use disorder for methadone, over time, as the body composition changes with pregnancy and weight increases, they have to increase the dose of methadone very carefully during pregnancy. And then after pregnancy, right, weight drops, not all of it. And so there's a very fine tuning of dose for medications for opioid use disorders, I know about at least, after pregnancy. And that's one other reason why we have this overdose risk, is they have to make sure that dose is right, where it's controlling the withdrawal symptoms and the what am I looking for? The want to use substances, while not giving too much. And so it is like kind of a delicate balance, along with all of the hormonal changes that affect it as well. And that's not even like really considered in the clinical space at this point.
so there's a great question here about trauma. So trauma-informed care is so important. Have you found that organizations are open to this, or are they hostile to being, to being understanding of trauma? Anybody?
and I can only really speak in this context for about trans women,
Mm.
but yes is the short answer. No, sorry, no, no to being open. I mean,
Mm.
if so, NHS services, gender clinics that in the UK, they don't have any trauma training for their when they're engaging with transgender people. No
So
trauma
that's
at all. So an assessments, particularly the first assessment. I think it's, because women are asked about their experience of, their childhoods. If child sex exploitation or abuse has occurred, then they're asked specifically about that, because there is this issue about the connection between a transgender experience and child sex abuse. A stereotype there about that. So yeah, I mean, it's so shocking to me that the first encounter, which we know is really important for women that experience any kind of abuse, at least in the clinical space for trans women, is not trauma informed. And I think this is such a massive problem.
It's mad.
Yeah.
That needs to change.
Yeah,
I mean,
and
so much needs to
I
change.
think, Joe, just going beyond the kind of trans women experience, just more generally
Yeah,
in drug services,
yeah,
that
absolutely.
should be the case for our drug workers. But
Absolutely.
yeah,
Yeah, yeah, yeah. So there's another question on hormonal. This is a good one. Hormonal fluctuations during the menstrual cycle, or um, in trans women in pregnancy, affect cravings and relapse risk. That's very interesting.
Mhm. Yeah, absolutely. We see changes in substance use patterns throughout the menstrual cycle. As I said, we've got this sort of peak around very high estrogen, where people seem to have these more kind of they want to go to the party. That's the time when they're more likely to consume more alcohol and substances in relation to this. But then we also see at the end of the menstrual cycle, when people are often in more emotional distress, physical pain, they are more likely to use more substances during that period as well. And obviously, it can be, that's not to say both women would have those same changes within their menstrual cycle. We know that hormonal fluctuations are really individual. Some women may have virtually no symptoms of things like premenstrual symptoms at all, yet other women with PMDD, for instance, can have, almost 2 weeks straight of extreme mental distress. So, depending on how you respond to the hormones yourself will also change a little bit how much your behaviors change within the menstrual cycle. But there's quite a bit of literature. I think perhaps even yourself, Amanda, may have done some literature looking at how was that, I can't remember if it was you or someone else, how substance use changes throughout the cycle. And then again, we have to think about what that might look like for women going into perimenopause, right? These are often,
Oh yeah.
yeah, starting at kind of, mid 40s, going on for 10 years, that is a really significant part right in the middle of your life, when you're probably, peak career, peak family life, peak everything.
Yeah.
And how much your relationship to your mental health and well-being changes there. And then also, as I say, we do glamorize, and I'm really, really glad that you brought it up, that this glamorization of alcohol use amongst women, this sort of wine o'clock kind of jokey thing, like actually, when if we think about the age group as well, that often is characterizing, perhaps these are women who are suffering with sort of early perimenopausal symptoms, and we're there offering them buy one get one free gin and tonics, which is perhaps not the right way.
No, that was great. Yeah, the bottomless brunch thing, and it's just shocking, isn't it? It's horrendous.
I think there's also an issue here around, because I noticed another question about the focus on youth, and obviously when we're talking about raves and clubs and festivals, you just kind of think of young people, but there's also, because we've had 30 odd years of rave culture now, there's also older women that still go out,
Yeah.
and I think they're again thinking about who's in, which groups of women are women more generally invisible in this space, but particularly aging raving women
Yeah.
are also very kind of invisible as well. So I think that's an important.
Oh, absolutely. Yeah, yeah. Very, very true. Yeah. Yeah. No, that is a really good question. Um, I think, have we answered most of them? MDMA being adulterated with fentanyl in the UK at the
Um,
moment?
I haven't heard much of that, to be
Mm.
honest. No, no.
But I
I
noticed,
know there was some issues around nicotines
yeah.
in ketamine, so you've probably seen some of the alerts about that. But yeah, not that I've heard of. It's quite. It's I mean, it's off because we had the drug-related deaths data out
Oh,
yesterday. Yeah. So I think there was so they've gone up again across the UK, and I think from MDMA, I want to say 79 people have passed away from MDMA consumption. But I think the majority, if I remember, I think it was about 30 of those were from just MDMA. So yeah, so in that sense, I'm not sure about adulteration, but I haven't heard much about that.
I mean, there's not enough testing, is
No,
there?
I don't think that's the thing, isn't it? Yeah, there's not enough testing in the UK, and it tends to be, yeah, tends to be quite at the back of house. So there, isn't necessarily that information getting out to the young women that are actually taking the substances in
Yeah,
those spaces
yeah.
themselves. So
There's not enough funding, there's not enough harm reduction. Government are moving away from harm reduction, things like safe injection facilities. They should be absolutely ashamed of themselves. It's
yeah, going in the wrong direction.
absolutely ashamed of themselves. It's
True.
terrible.
Yeah.
It's the same for the US, despite the infiltration of fentanyl. Harm reduction is kind of a dirty word in the US. And as of a couple months ago, via a new executive order by President Trump, it outlawed essentially any federal funding for harm reduction services in the US. So all of the harm reduction organizations we had were essentially defunded. A few months ago in the US. So anything that is being done in harm reduction space in the US is through private organizations or people. I work with our opioid data action program in Florida. Are just kind of trying to support. These are county health departments funded by the state, funded by federal level, are working with nonprofits to do the work, but they can't do it themselves. So they're supporting where they can, but it is quite unfortunate. Even we cannot do needle exchange in Florida. That's not allowed.
Really?
They can't do fentanyl test distribution. Other nonprofits have to do that. So it's quite an issue. And I think so. From my understanding of the drug supply, a lot of the fentanyl comes from Mexico, is why a lot of our drugs are contaminated. That's where it's coming from. So I guess the nice ocean protects you a little bit from that. But it is certainly an issue, and even fentanyl testing strips. So you give somebody that and it tests positive, right? So they know most drugs do have fentanyl in them. Then what does the person do? Like, research hasn't gone to that step, right? Then what do? They just know, like, maybe I should take a little bit less this time. They're probably still going to take it, right? Like, so there's really no like messaging to say, okay, so your fentanyl test strip is positive. Now what? Like, you can't just go buy drugs from somebody else very easily when they're illegal. So,
Mm.
Yeah,
yeah.
it's a really good point, actually. And I just talked to Fiona Measham of The Loop recently about the hell that she's gone through to be able to do some drug testing at festivals, even at festivals and city centres. It's just mind-boggling. Just for a minute, I want to talk about psychedelics. So, are there any guidelines, Grace or Amanda, that you or anybody knows of for women using psychedelics? Because actually, that's a kind of such a rapidly evolving
Mm.
space that area that it's possible that that's around.
Yeah, so I mean, we've been trying at Hysterica obviously to
Yeah.
bring the conversation forward and try and have that. But in terms of guidelines, I mean, guidelines can only exist once we've got data with which to
Mm.
draw them on, right? So we're kind of lacking enough information to give really clear guidelines. What we can do at the moment is discuss, a little of what I presented to you, albeit very briefly. And if you do want to find out more, please do visit our website. But we see these huge influences on the same systems within the brain, like the serotonergic system. Now, that could cause a safety issue in a potential way where if you've got very, very, peaking estrogen levels, you've got increased reactivity and activation within the serotonergic system. So are you then, theoretically at more risk for developing something like serotonin syndrome? And theoretically, yes, but without kind of good data, we can't really say that for sure. But one thing that we do have pretty good evidence of. And this evidence comes, originally from talking with indigenous communities, for instance, who don't allow women to sit in ayahuasca ceremonies. I'm sure most people on this call know what ayahuasca is, but it's a psychedelic substance with DMT that is brewed in the Amazon jungle and very much part of their indigenous and cultural heritage. And they have these practices where they don't let women come and sit in ceremony. Now, sometimes it's kind of spoken about in a spiritual aspect and how, having women in the space can disrupt the energy. But if you actually think about it, perhaps it's more to do with the fact that women are not really suitable to sit with the medicine at this time because of the stress that it has on our system. And it is a stress on the system to take a large dose of psychedelics.
Yeah.
Because of the fasting practices that often take place around ayahuasca, because of the practical, the physical discomfort you might be in at the time, the practical need to go to the bathroom and have to do some administration in the middle of a psychedelic trip. So, these are the kind of origins of where this knowledge comes from. But we've been collecting a survey at the moment on women who've taken psychedelics, and we're starting to see some of this come out in our data and certainly in people's trip reports, that if you are particularly one of these women who really suffers with a lot of the kind of mood and cognitive effects of being close to your menstrual cycle, that actually your mindset is fundamentally changed by
Yeah.
menstrual cycle. And if your mindset is such that you're in, a particularly anxious or, dark place with a lot of intrusive thought patterns, and you take a large psychedelic at that time, well, it's an internal amplifier. So
Yeah.
you are likely to have more negative experiences. Now, for some people who are very well practiced with psychedelics, maybe this is an opportunity for you to see beyond, the cloud or the lovely estrogen haze, to what is really annoying you or whatever it is that you're trying to achieve within your ceremony. But on a wider level, I personally believe, particularly when we're thinking about clinical populations, using psychedelics in this last bit of the menstrual cycle could be more likely to induce people to have a negative experience, and that could in itself then impact their outcomes. And
Yeah.
furthermore, just finally on that, we do see a peak in suicide ideation during this time. And it could very well be that people who were medically screened several weeks earlier seemed very mentally stable and appropriate for the use of the drug, may then in those final days be, having high suicidal thoughts, that actually a psychedelic can actually intensify in some situations. So there is a couple of risk factors there.
I wonder, in the clinical trials, do they ask people to track their menstrual cycle? I don't know that.
Well,
They
if
should.
someone in their research team has had the unfortunateness of being near me in the last year, then they probably now, but they certainly haven't been. And it's really important that we do. But furthermore than that, it's worse than that. The majority of women in all clinical trials are required to be on 2 effective forms of contraception, most likely a hormonal contraception. So most of the clinical data that we have, full stop, doesn't account for hormonal fluctuations because it doesn't really occur in a natural way in the clinical populations that we're testing.
Grace, so I'm seeing a naturalistic study coming up. We could do that, couldn't we?
We absolutely could. Yeah. Yeah. And I think that's a wonderful way. We know that people use these substances. I love a bit of citizen science. I love going out to the
Yeah.
community and saying, what do you know? You tell us so we can tell everyone,
Yeah.
because in the kind of lack of good science and good oversight of women's biology in any aspect of drug use, we've got a lot of catching up to do.
Yeah. Yeah. Absolutely. Yeah. Yeah. And Amanda, you've done some work on breastfeeding, people taking psychedelics while they're breastfeeding.
Not specifically. Well, I did a survey about maternal psilocybin use, kind of the same a few years ago. Awestruck that there was such limited data around maternal psychedelic use and women's psychedelic use in general. So I did a survey on psilocybin use among moms. We're working on that analysis now, but it did find about 12% reported using psilocybin during during breastfeeding. Sorry, the percent that reported during pregnancy was pretty low. It was like 6%, which was like 6 people. out of the 100 sample that we have. So it didn't limit to just prenatal use because we wanted to be able to get a sample, number one. And so we did find, though, that moms reported overwhelmingly positive mental health changes following psilocybin use. Some decreased substance use, mainly tobacco and alcohol use, actually, were the main decreases in substance use that were reported, and improved parental experiences, including improved or increased empathy, increased patience, and an increased ability to be present with their children.
Yeah.
So, overwhelmingly positive outcomes that were reported among moms using psilocybin. We did have a few negative outcomes reported, including decreased overall mental health. There was like 6 people that reported negative mental health outcomes, some of which reported positive also. So, I think there was only 2 people in the sample that reported only negative mental health outcomes. Um, so some interesting data, and that was sort of my like pilot step one of looking at psilocybin use among moms. I'd like to expand on that and do some more quantitative research, asking more about differences that we found in lengths of outcomes that moms reported. So some of their changes in mental health lasted 1 week, some of them said a year. So a lot of that is probably due to dosing. So we had about 50-50 that reported microdosing versus large doses of psilocybin. And then we didn't dig into the menstruation factors of that or their hormonal differences, which I think is fascinating. So a lot of work to be done, but we do know some. So hopefully,
Yeah.
trying to get those
Yeah.
papers out this fall.
Great. So look out for those papers, everybody. So another question for you, Karenza, about or is this for Amanda? Probably for both of you. Why are Black women disproportionately screened for drug use in the US when there's no evidence that they use drugs more than women of other racial groups?
Racism.
I don't think,
Well,
yeah,
that's
yeah, I think that's the simplest
yeah,
answer to that
yeah,
question. Yeah.
yeah. It's racism. It's
Mhm.
appalling.
I
Um,
think I think one of the other interesting things, if you're thinking about history of global drug prohibition, is the way that it was, its emergence very much rooted in the control of Black populations
yeah,
post-slavery. And so, if you look at this kind of long history, what we now are on 120 years or something of prohibition, and I think, yeah, it's baked into the system, basically, racism, racialization, thinking about intersectionality. We were talking about intersectionality before as well, weren't we? That intersection of sex, gender, and race, sexuality as well, obviously. So
yeah,
yeah.
yeah. Well, long and horrible,
Yeah,
Black
horrible.
families are also more likely in general to have their children removed in the
yeah,
US, even
yeah,
not even accounting for substance use at all. So
yeah. It's the same in the UK, Amanda. Yeah.
Yeah, the racism of our drug laws as well. Yeah, as you said, Karenza. Yeah, it's a long and horrible history.
Yeah.
Um, and then there is a colonialism issue with psychedelics as well that we probably haven't got time to go into, but the West appropriating medicines that have been used for thousands of years by indigenous people,
Mhm.
and turning them into patented medicines. But we probably haven't got time for that. Um,
That's a whole nother episode.
a whole other webinar.
Actually, we have done that with ICers on the podcast. That was fantastic. I learned so much. That was fantastic by then. Have you, I think we probably have to finish. Um, Although I'd like to talk to you all day. Three such brilliant women. So good. Um, have you got a sort of final take-home message for the audience? It's a bit tough one, but
uh yeah, stay safe out there, girls. Probably the number one, but yeah, get to know your bodies, get to know your hormonal cycles, and it's take them into account with anything you do, any activity at all, but just be aware they are influencing you, and you should pay attention to them.
yeah, brilliant. Yeah, yeah. And talk to your friends about it, everybody about it.
I would say, bring up the hard question. And, I'm often when I go to conferences or in spaces that are very male dominant about substance use or really any health condition, say, what about moms? What about women? Why are we not focusing on this? And bring it up and just, raise awareness around the need for women focused research, and the lack of understanding of all these different phases and all these different factors that affect half of the population in the world, and the only population in the world that brings about life and births people. So
Wow. Yeah, that's fantastic. I think that just what I ended on really that this is a social justice issue. We're just talking about racial injustices in relation to drugs, and I see this whole space as it's about social justice for all women, whether pregnant, trans, black, whatever. And also, I think, and this relates to what you're saying, Grace, is that we've got so many fantastic resources as women, and we're also have loads of connections as well, and working in this really male dominated space, whether it be science, scientific community, whether it's raves, whether it's about, I know, drug dealing markets, all that kind of stuff. I was thinking, I didn't get a chance to mention her, but Jennifer Fleetwood's work about women who are drug mules, all that kind of thing. There's such an interesting space for us all to kind of work in, and I think we should kind of take heart, I guess, from how good we are at connecting with each
Yes.
other, and that kind of.
Absolutely. Yeah, yeah. Somebody's asking for this to be a regular webinar. It's really nice. That's so great. Oh, it's been amazing. Look, thank you all so much. And thank you to the audience. Thank you for your questions and your participation. This is all of us in this. Um,
Thanks,
yeah, so
Joe.
thank you very
Thank you.
much. Been absolutely brilliant. Thank you.